I too look at my topic and I say, really more? But I promise I will make it as interesting as possible. Something that I tried to pick out some things that Dr. Prosh didn't address, right, or touched upon. So some of the things that we encounter commonly is sarcoidosis. And we know that stage 4 sarcoidosis is the end stage, the pulmonary fibrosis of sarcoidosis. And anytime we see an upper lobe predominant pulmonary fibrosis, as he said, we think of hypersensitivity pneumonitis. We think of pneumoconiosis. We also think of sarcoidosis. How do we improve our sensitivity and specificity amongst those things? Yes, lymphadenopathy can help, but lymphadenopathy is also seen in silicosis and borreliosis, not usually seen as much in hypersensitivity pneumonitis. This is a very nice case of sarcoidosis, and you can see the thick, very enlarged hilum in this patient with stage 4 sarcoidosis. About 20% will progress to this stage. How about this patient? All right, this is something where maybe the lymphadenopathy is not really seen much anymore, and we have these symmetric masses. Obviously for us, when we see symmetry of masses in the lungs, we think, oh, hopefully benign, right? This is a very particular appearance. This is something that you may encounter routinely in patients in multiple diseases. This is the PMF, progressive massive fibrosis picture. All right? I can't look at this and say that this is silicosis, borreliosis, or sarcoidosis. It could be any of those, but at least you have a starting point. All right? Because this person is from New York City. They've never worked in a mine. They've never worked in a light bulb factory. That's where a lot of the borreliosis was in the United States. All right? This is truly a sarcoidosis patient at end-stage fibrosis. These masses are actually cicatricial atelectasis, right? Remember when we had to read, as residents, we had to read about the different kinds of atelectasis, and we said, really, I have to learn about cicatricial and relaxation atelectasis and such. This is the atelectasis of the lung that results from fibrosis. This is what it looks like on CT. This is the CT scan of this patient, all right? And I'll tell you that sometimes I'll look at the X-ray or the scout image and say that's a lot easier to dictate than this, right? This is terrible. But if we were to use the words that we want to use to describe these things, we would talk about areas of cicatricial atelectatic changes, bronchiectasis, all right? Retraction and architectural distortion. We love to use that word architectural distortion because it gets me away from talking about spiculation and things like that, right? So for us in chest, anytime we see straightening of the vessels or the airways, that's architectural distortion. Another case of sarcoidosis, very similar, and you can imagine on a radiograph, what this looks like, symmetric masses of progressive massive fibrosis, sarcoidosis. Just to show you how near identical pneumoconiosis can be, I know he talked about silicosis yesterday. These are two interesting patients, this patient and the one that's following. They worked in a light bulb factory outside of Boston, and the way they used to do light bulbs was they would have the filament of beryllium in their mouth, and the bulb would come down, and they would take the beryllium filament and put it in the light bulb, and then it would go down the line. So you can imagine these workers having beryllium filaments in their mouths for decades and inhaling or swallowing little pieces of that beryllium. And that's how they got this sort of architectural distortion, retraction, cicatricial atelectatic changes. This is what her CT scan looked like, right? And this is from borreliosis. And this is a similar patient, same light bulb factory, almost looks exactly like sarcoidosis, right? Where you're saying, okay, there's hilar retraction, juxtaphrenic peak sign, there's a lot of reticular and architectural distortion here. Is this just sarcoidosis? You know, obviously in your patients, if you saw this in a 20-year-old, you'd be like, okay, this can't be from a mine. And usually our hypersensitivity pneumonitis patients, right, the chronic ones with the fibrosis, that takes some time. We would think this would be sarcoidosis, but this is also from beryllium, a pneumoconiosis. All right, very similar to sarcoidosis. Another entity that he touched upon, but I wanted to sort of further the imaging features of it, was cryptogenic organizing pneumonia. Now, I know all of us, we have COVID fatigue from all the organizing pneumonia we saw. And I think it really did teach us a lot about this entity. Obviously, cryptogenic organizing pneumonia is the pneumonia that any of us could get, all right, because it can be spontaneous, and it has a multitude of appearances, all right, and all of us now are organizing pneumonia experts from COVID. But some of the words that we use to describe cryptogenic organizing pneumonia or organizing pneumonia are very important, all right? Some very specific signs we're now very familiar with, particularly the reverse halo or the atoll sign, all right? Some that we still get a grasp on or are trying to use a little bit more regularly are these, the perilobular opacities. This has been called the aqueduct sign, and I'll show you that shortly, all right? We know that in general, it can be starting centrally and move to the periphery in COVID, all right? Unfortunately for cryptogenic organizing pneumonia, it's almost the same. It can be central, it can be peripheral, all right? Some things that are not seen in cryptogenic organizing pneumonia, however, are little small nodules, all right? Small nodular consolidations, meaning 1 to 2 centimeter little things like that. I usually only see that in immunotherapy-related drug reaction, all right? Not in organizing pneumonia or cryptogenic organizing pneumonia. And I don't usually see halos either, all right? I see reverse halos in cryptogenic organizing pneumonia. So here are some examples, all right? Look at the beautiful, right, reverse halos. There's consolidation and then ground glass in the center. This is a peribronchial location with bronchiectasis. Same thing with this patient, beautiful, almost traction bronchiectasis, right? I'm trying not to use that word, but it's pulled so straight, you know, almost like traction bronchiectasis. Very faint ground glass, but adjacent consolidation, right? This is the sort of reverse halo that we talk about. This is probably my best images of reverse halos. You can see beautiful consolidation, a peripheral location, a central clearing, all right? This, I think all of us know that this is going to be cryptogenic organizing pneumonia. This is the tough one, all right? We do see this sometimes, and as they come out with more and more agents to treat cancer, this may be the drug reaction you see. And of course, it can be very difficult to describe because you might say, oh, is this subpleural reticulation? Is this maybe some architectural distortion? Am I looking at some fibrosis? All right? Maybe you wouldn't want to use the word fibrosis. Yesterday, he discussed the mortality of that word, all right? 3 to 5 years, dead. Faster, almost faster than many cancers. So be careful when you use that word, all right? I use a lot of treatment-related changes, possibly treatment-related changes, and that really gives, or drug reaction, that really gives a clinician some time to figure out, well, he's not on any drug therapy. Let's discuss this. Or two, you know, let's open up the discussion to what else this could be. This is the cerebral aqueduct sign. You see, right? I mean, like sort of like the waterways in Rome where it's sort of going over and over and over. That's what they call the aqueduct sign. And these are the perilobular opacities of cryptogenic organizing pneumonia. Lastly, just like we saw with COVID, if you keep getting organizing pneumonia or if you keep getting cryptogenic organizing pneumonia, then you will head towards fibrosis. The lung is not going to be happy about this pneumonia hanging around. Then it will fibrose. And now we start to see some of the features that were discussed yesterday. There is some subpleural reticulation here. There's some distortion. There's bronchiectasis. This patient is laying on their stomach, right? This is not atelectasis anymore. This is truly fibrosis, all right? It can often mimic this NSIP pattern, all right? And he mentioned that NSIP usually is very homogeneous and has a lot of ground glass, all right? And you can see this is very homogeneous. There's no honeycombing, okay? And there's a lot of ground glass. Okay, I laughed yesterday because he talked about cystic lung disease and he says, oh, we don't want to go into that, all right? But then he talked about all this interstitial lung disease, and I said, well, what am I supposed to talk about? I guess now I'm going to talk to them about cystic lung disease, so that's what I have here for you. Now, the cystic lung disease, what I did here was I did make sure to include some of the interstitial lung diseases that he spoke about as well, but I also put in some things about cancer and lymphangiomatosis, so sort of the interstitial lung diseases that are non-fibrotic. Okay. So how are cysts made in the lung? We take the bronchiole, and it either becomes blocked by tissue or irritation or fibrosis, and then basically it bursts, all right? And you're left with this relatively thin wall of an air-containing structure. The differences between a cyst and a cavity, I think, are quite clear, all right? Remember that your tests and your books talk about how in a cyst, the vessel is pushed to the periphery, all right? But in emphysema, all right, the vessel is still in the center of that airspace. In the literature, they talk about the thickness of the wall being something that really is used to discriminate whether or not it's a cavity or a cyst. You know, I think all of us can just look at this here and the irregularity here and then not take calipers out and know that that's a cavity. And once you use that word cavity, you know that you're going to be exciting your referrer because they're going to say, so you think it's TB, you think it's squamous cell cancer, you think it's something bad if you use the word cavity. All right, so I do make a point to say, am I ready to get some phone calls because I'm going to be describing a cavity here. And this is obviously, this is a patient, I believe, with pneumocystis, all right, chronic pneumocystis. They could not, they threw everything they could at this patient, and they could not get rid of the pneumocystis. And this here is tuberculosis. One of the things that we talk about for cysts versus cavities is, one, that the majority of cysts, except maybe when we see it associated with ground glass and adenocarcinoma, cysts are something where the clinicians they say, okay, we have time. This is probably something that they can figure out, and they have time to sort of work out the differential. For a cavity, however, as I said before, if it's not going to be an aggressive organism, they're going to think it's an aggressive cancer. So if you look at this, all right, this is an adenosquamous carcinoma, all right, and I think all of us would say it's irregular, maybe spiculated, area of cavitation in the center, all right? But what about this, all right? When there's an air fluid level within this sort of cavity, and then this, when there's an air fluid level within the cavity, which is which? Which is benign and an infection? Which is cancer? I can tell you that it is a lot less common to see air fluid levels within cancer, all right? But of course, this is something where you would tell your clinician, look, I think this is infection. You might want to give it some time, but obviously we have this can be cancer, all right? This was squamous cell cancer. This is one of the very few squamous cell cancers I have with an air fluid level. Of course, I have many, many, many squamous cell cancers that have internal necrosis, low density inside, but not an air fluid level. And then this one over here was an abscess. All right, and this one just took a lot of time to clear. This is what he didn't want to discuss, and so I'll be discussing every single one of these. No, I'm not going to discuss, but we're going to go through some of them very quickly. All right, so this is some of the things I'll be discussing. I know, again, I was telling my wife I had to discuss pneumonia with you, I discussed pleural effusions with you, now I have to show you a bulla, all right? But I think what's so interesting about bullous emphysema, since all of us are from countries where there's a lot of smoking, is again, in the future, as we progress towards what can we do for these people, all right? We can collapse these lobes. Surgeons can resect these lobes and improve ventilation and perfusion in this sort of, in this compressed lung right here, all right? So this is something that should either be resected or collapsed, and then this, the ventilation and perfusion in this lobe will improve. We all know about alpha-1 antitrypsin, all right? These patients have unopposed elastase activity, and then this very particular emphysema, all right? We've all seen central lobular and paraseptal emphysema. It's just these holes in the lung, but this is very different. You can see that the dot of the pulmonary artery is in the center of this, right? So it's not a cyst, all right? But the whole secondary pulmonary lobule is distended and empty, all right? That's panlobular, panacinar emphysema, All right, that's always been the question on all your tests. Panlobular, pan-acinar emphysema, seen in alpha-1 antitrypsin. Usually, the emphysema is usually more lower lung predominant than upper lung predominant, okay, but it can be quite diffuse. Honeycombing. He showed some beautiful cases of honeycombing where all of us know that if we see a patient with fibrosis, with honeycomb cystic changes and traction bronchiectasis, it's probably going to be a UIP pattern, all right, related to a multitude of things, or it can be sort of idiopathic and be IPF, and we know that the mortality is quite high. However, we also know that unfortunately many of these fibroses don't have honeycombing, including UIP. There have been some arbitrary rules given to honeycombing in the past. They used to say it should be 3 tall and 3, side by side, and now it's changing to like maybe 2 on top of each other and 2 side by side, okay? But just so you know, to do interstitial lung disease very well, it takes a team. It takes a team of radiologists, it takes a team of pulmonologists and pathologists, okay? We actually have every month 4 interstitial lung disease conferences, some with pathology, some without pathology, all right? So don't feel like you have to have the answer right away. At least be the one to say, hey, this is definitely a lower lobe predominant pulmonary fibrosis pattern, right? It's lower lobe predominant, it's not upper lobe predominant. And I think I see a wealth of honeycombing, so I'm leaning towards UIP. So clearly, in these patients with a wealth of honeycombing, all right, you can lean towards UIP. And the directionality is very important, as he said yesterday. You can see how this is almost completely normal, this lung, and as we get down to the lower lobes, the fibrosis gets heavier, okay? Unfortunately, fibrotic NSIP is also lower lobe predominant and can also have honeycombing, but not as common as UIP-IPF. UIP-IPF is the most common fibrosis. So if you're going to say one fibrosis, this is the one to say, right? This, they said, is about 70-80% of all fibroses is going to be this, all right? If you're talking about something in the upper lobes, don't say UIP-IPF, right? Always consider your hypersensitivity pneumonitis, as he said, all right? But if it's lower lobe predominant, once in a while they'll say, hey, guess what? It came back hypersensitivity pneumonitis. You say, okay, but we know that that can happen. I love this case. There's almost so much honeycombing. Where's the rest of the fibrotic features that he showed yesterday? Where's my subpleural reticulation? I can barely see the traction bronchiectasis. I see almost no subpleural ground glass. This is just completely fibrotic, burnt-out lung. This patient had rheumatoid arthritis, right? So this is UIP, just a beautiful example of honeycomb cystic changes, basically almost eradicating all the other features of pulmonary fibrosis. I think he mentioned asbestosis yesterday, and I'm going to show, and I showed you some cases at the pleural talk of asbestosis. This is the same case, and I did want to show you again some of the irregularities of fibrosis here. The UIP case I showed you, the honeycomb cystic changes was too much. It's obscuring a lot of the detail of fibrosis. But in this patient, you can literally see, you can see the vessels being pulled straight and backwards, right? That's our architectural distortion, all right? You can see the subpleural ground glass. You can see the reticulation, these little lines coming out, all right? Those are all the features of fibrosis. So when you, just similar to, as I was saying, when you're all describing so beautifully your MR sequences and your findings, it's the same thing. Once I start saying those words, I know I'm dealing with a fibrosis, and then I just have to decide, is it lower lobe predominant or upper lobe predominant? And in this case, with these gigantic pleural plaques, I know that this UIP pattern is related to asbestosis. This is a case of chronic hypersensitivity pneumonitis, all right? Look at these lower lobes, right? They're relatively spared. I have interlobular septal thickening, distortion, subpleural reticulation, some maybe honeycombing in the upper lobes, all right? This is why you would say this. You would say that, okay, this is an upper lobe fibrosis, okay? And if I think about what are the differentials for upper lobe fibrosis, we think about, we said before, sarcoid, we said silicosis, borreliosis, and chronic hypersensitivity pneumonitis. If you look, and it's quite subtle, there are some areas, right, of decreased attenuation. These are areas of air trapping that would be further brought out on expiratory images. All right, again, it takes a team. If the doctor doesn't suspect interstitial lung disease, you may not have expiratory images. So just if you're heading down that route of saying, oh, I wonder if I should say chronic hypersensitivity pneumonitis, but they didn't order an interstitial lung disease protocol CT scan, that's for you to recommend, that you suspect this entity and that maybe the patient would benefit from expiratory images. And then these would be confirmed to be areas of air trapping, which it was. Drug reaction, right, has many appearances in the lung. You can have, in the old days with platinum-based agents, we would get a fibrotic NSIP when we had a drug reaction, which would basically look like what I showed you before with the cryptogenic organized pneumonia, just some subpleural ground glass. So it may be something like this, just this part of the lung. So any peripheral ground glass in someone who had breast cancer or lymphoma and was getting platinum-based agents, we would be, that's drug reaction. But you could also have a UIP pattern or even a hypersensitivity pneumonitis pattern as a pattern of lung injury or drug reaction. You can look at this patient and be like, well, there's honeycombing here, and he's making cysts, and there's traction bronchiectasis. All right? So this is almost like a UIP pattern. All right? And this patient was given amiodarone by 5 hospitals in Manhattan, but never followed up with any of them. He would get his prescription for amiodarone, and then when it ran out, he would go to a different hospital. And slowly, over 2.5 years, his clear, normal lungs became this. All right? This is fibrosis from drug reaction. All right? And it was completely normal 2 years before this. Pneumatoceles. So I've shown you several cases of PJP, and we know that pneumatoceles, these little infectious cysts, are oftentimes part of pneumocystis. These cysts, the walls can get a little thick if the patient is, if they can't get rid of the PJP. If it's a chronic PJP case, it can almost be cavitary, all right? Be careful, again, when you use cavitary, because obviously if this patient has AIDS and then you're talking about cavitary disease, then they're saying, oh, so you think it's PJP and another fungus, all right? Sometimes you might have to be like, no, I think it's just now the walls are thickening up because they can't get rid of the PJP. So this is a case of this patient had PJP for 4 or 5 months. They could not get rid of the organism, and eventually the wall started to thicken up, okay? And, I could track this over time. I didn't call this a separate organism. I just continued to call it PJP, PJP, PJP. There is some subtle central lobular nodularity in here, some tree and bud in here, all indicative, all the words that we've used before of atypical organisms, all right? And again, sometimes PJP does not have that beautiful crazy paving that we discuss. It will definitely usually have a lot of ground glass, but there will also be little nodules associated with it as well. These patients, of course, can suffer from very large tension pneumothoraces, oftentimes bilateral, all right? So sometimes you have to be quite careful. They'll cook along for several days or weeks in the hospital, and then all of a sudden they'll have bilateral tension pneumothoraces. This is an interesting case. I don't know how many of you have cystic fibrosis patients in your population, but I think if you study and read about cystic fibrosis, it's supposed to be upper lobe predominant. This is lower lobe predominant. And 2, this patient was actually African. All right, and I think cystic fibrosis was uniformly for Caucasians. So obviously, there was a mixture of genetics that affected this patient. And when you have bronchiectasis, all right, you are sort of forever at risk for a multitude of organisms, including Pseudomonas, all right? And this patient, with her terrible bronchiectasis, suffered from horrible, horrible infections. And they just could not get her to lung transplantation, which we know is what benefits many of these patients. And she eventually did die very shortly after this CT scan of another pneumonia. But you can see how I can't even track these bronchi to the hilum, right? But these truly are all dilated bronchi, but it almost looks like honeycombing, right? But this was cystic bronchiectasis. Trauma can also give you cystic spaces in the lung, all right? And it can be kind of cool to see them because you're saying, oh, like, what was the mechanism? Was it penetrating or non-penetrating, all right? And you can get cystic foci filled with blood and air in the lung in penetrating as well as non-penetrating injury. So I'll show you some cases. So this one here, all right? This patient had a non-penetrating injury, all right? And this was a rollover from a high-speed vehicle, all right? So nothing penetrated the chest, but this was areas of multiple lacerations in the blood, in the lung, right? And these were sort of pneumatoceles, right? Blood, air of laceration in the lung, all right? And this is all filled with blood and air, okay? And then these are areas of contusion from hitting, the side door, the steering wheel as the car flipped over and over again. What about this? I don't think this is unique just to the United States. Oftentimes to join these gangs, they will beat you to be accepted, and if you live through the initiation, then you're part of the gang. So this is someone who, I used to say this is a first-year resident. This is how you get into residency. And this is someone who's post-beat into the gang. And this is no penetrating injury, all right? This is all fists on this person, all right? And you can see all these faint ground glass or hazy opacities on the X-ray. But look at the CT scan, right? You can see that this person had a very particularly strong person on the left side who kept hitting him over and over again. And this person's fists were able to rupture and lacerate his lung without any penetrating injury and cause these hematoneumocele in his left lower lung, a little bit over here as well. The right-sided people, whoever was beating him on the right side was not as strong, right? Because they didn't create those lacerations. This is a screwdriver attack, right? Sometimes it's not a knife, sometimes it's a screwdriver. And obviously, the X-ray does not show the true trauma to the patient. It just hints at the trauma. But here it is, right? And this is obviously the direction of the screwdriver and then the multiple lacerations in the lung. So I said to be careful about using the word cavity, all right? But the good thing about an infectious cavity, if you do get the feedback, oh, yeah, we think it's healing fungus or healing tuberculosis, is eventually, if it goes in the right direction, it will become a cyst, all right? We know that in a regular 3-centimeter cavity, as it heals, will contract down and the walls will get thinner, okay? So this is a patient with cryptococcus who had multiple nodules that eventually cavitated, and then he was left with just multiple cysts, all right? And this is them getting better and getting better, all right? But these used to be quite thick and irregular before they reached this stage, right? They look very similar to this, all right? And you can see that this is someone who's just had chronic septic emboli, where different stages of healing, right? This one is further along in its contraction, so this is much older than this one over here. This is an intravenous drug abuser who just keeps using, all right, dirty needles, and this one is more acute. This is one that's healed up quite well. I'm gonna keep going here. This is the case I showed you before. What I didn't show you was this radiograph, which I love because, this is the mysteries of cystic lung disease, right? They're here, they're just hidden. But it's quite beautiful where you can see some cysts and some cavities and nodules in this intravenous drug abuser. This is another patient, also intravenous drug abuser, and again, right, you can actually see that there's a cystic or cavitary nodule here in the left upper lobe, all right, and then it's only when you do the CT scan that you can see that there's a peripheral predilection, all right, because on this X-ray, it could be anything. These could be in the middle of the lung, in the center, and then you would say, oh, is it squamous cell mets? Is it what kind of infection? Any type of infection? But once it has a peripheral predilection, then we know it's septic emboli. Echinococcus. So these images were shared to me from some colleagues who would routinely go to Ethiopia to share in their knowledge of radiology. And this is such a fascinating entity. We also see it in other countries. Peru and Yemen, I think, also are quite famous for echinococcus. Can you believe that one patient I had, the pulmonary team came down and they said, there's something in the lung. We want to show you something in the lung, and he is a farmer from Peru. And I said, echinococcus. And they said, no, it's not echinococcus. I said, TB. He said, no, it's not TB. You know what it was? Just a regular abscess, just a regular plain abscess. But, we think about that, right? That's part of our epidemiologic skills. So this is just a beautiful example of this multi-layered sort of daughter cyst that's going to form. When this collapses, right, you get these multiple layers, right? Multiple layers of the cyst. It rushes into the tracheobronchial tree and connects and collapses inside, right? And they call that the water lily or Camelot sign. All right? It can be very difficult, but the differential is not that. When you see them, the differential is quite small, because if it's not a conventional abscess, we usually don't see such large liquefactive masses in patients. All right? Squamous cell is never this big, right? We don't see tuberculous abscesses this big. Usually, if it's a large fluid-containing structure in the lung, it's a regular abscess, or two, it's going to be related to echinococcus. Going this way. This is another one. This is someone from Yemen, all right? And all this was a simple fluid. You can see how the density of it. And that's it. It was never ruptured, and they removed it, and it was echinococcus. Amyloid. Okay. Amyloid is an interesting entity. We're going to see it more and more as multiple myeloma, and the diagnosis of multiple myeloma sort of permeates through the medical society. 10% of patients who have multiple myeloma develop manifestations of amyloid. So for me, anytime I see MM in the history or MM, is someone telling me about that, I'm thinking about amyloid. I mean, I'm a chest radiologist, right? If I see cysts and nodules, I'm also going to be like, oh, does this patient have a history of multiple myeloma? All right? So classically, amyloid patients are very much similar to Langerhans cell histiocytosis in terms of they can have all cysts, all nodules, or cysts and nodules. All right? So amyloid is the same. What's very different is amyloid can have calcification, but Langerhans cell histiocytosis never has calcification. So if you see here, look at these weird calcifications that are part of these nodules. All right, that's very specific for amyloid. So you don't see it all the time in amyloid, but now you almost don't even need a biopsy. You're done, because there's only amyloid will give us cysts and partially calcified nodules in the lungs. This is the entity that he mentioned yesterday that is officially recognized as a lymphohistiocytic tumor by the WHO. All right, and this is a smoking-related disease. And it can be quite helpful, because if they stop smoking, all right, the lungs will clear up. And it can look very much like a horrible cystic lung disease, or two, almost like the worst emphysema you've ever seen. All right, and you can see, you could almost say that, is this all emphysema, or are there cysts inside? And if you look closely, all right, a lot of these lucencies do not have the vessel in the center, right? We said before that emphysema should have the vessel in the center, and cysts have the vessel in the periphery, right? This is someone with end-stage pulmonary Langerhans cell histiocytosis. I could not have made a difference in this person's life because they kept smoking and they had that disease. Maybe 20 years before, if someone had identified that they were developing cysts associated with their smoking, it could have been helped. Famously, pulmonary Langerhans cell histiocytosis spares the costophrenic angles, right? And you can see how normal the lungs look down here and how abnormal they were up there. This is another patient. So I'm sure every country has their either rich diplomats or rich financial people who love to look, fabulous with a cigarette in their mouth and dressed quite sharply. This is one of those people, and he kept coughing, and he got this CT scan. And you can see, all right, these bizarre cysts that were nicely described by Dr. Prosh yesterday, all right, that beautifully spare the costophrenic angles, okay? And one of my mentors was a very tough pulmonologist, and she told this 35-year-old, financial person, you need to stop smoking or you're going to die, all right? And he did, and this all went away, all of it, all right, completely clear. Birt-Hogg-Dubé, and I know we all love these diseases with 3 names to remember, but those of you who are inclined for abdominal imaging, all right, this is a story I hope that will sort of put this in your brain if it's not already in your brain. So the patient you're looking at here is the son of my wife's patient. So my wife's a dermatologist, and she had someone coming in with renal cancer and these bumps on her face. And so she biopsies these, and they come back as fibrofolliculomas. All right, and so this is a man who was already in his 60s, dying of renal cancer, and no one had connected the dots that he actually carries, the disease of Birt-Hogg-Dubé. All right, so Birt-Hogg-Dubé, it produces cysts in the lungs. They are highly predisposed to renal cancers, and they get this skin condition. So this is his 30-year-old son, who we were looking for lung cysts, and then we also looked for renal cancer. So fortunately, all right, he had no renal cancers, all right, but he was already making cysts. And this is someone who, obviously, if he goes on an airplane or goes scuba diving, he's at risk for spontaneous pneumothorax. And you can see here, all right, the rates are quite high, 34%, 24%, right? They can be quite high for spontaneous pneumothorax. And it's something where you want to make sure that they also don't have renal cancer. All right, so a very interesting disease. Again, just a few cysts. DIP is another smoking-related interstitial lung disease, desquamative interstitial pneumonia, and it looks almost like PJP. And the only reason why I want to show it to you is, 1, it is an interstitial lung disease. 2, it's a readily treatable interstitial lung disease. Stop smoking. Okay? And you can see what it looks like. Unfortunately, right, there's a lot of ground glass there. There's some cysts there, right? If we were just to look at this one image, we would think PJP, ground glass and cysts, all right? But, when you have smart referrers, and this referrer for this patient was a pulmonologist, and the history said, suspect smokers-related interstitial lung disease, evaluate. And I said, oh, okay, and you'll have to believe me, the upper lobes had emphysema, so I was able to read this as desquamative interstitial pneumonia. All right, and that's what it looks like. Ground glass in the lower lungs and some cysts, some emphysema in the upper lungs. Lymphangiomyomatosis, all right? Interestingly, we talked about how the WHO described PLCH, pulmonary Langerhans cell histiocytosis, as a neoplasm. It wasn't until I researched this topic that I was like, oh, it's actually a low-grade invasive neoplasm as well, right? This is actually a PCOMA, as per the WHO. These patients we all read about in medical school. They're quite famous for having chylous pleural effusions, having pneumothoraces, all right? Their lungs can oftentimes look identical to the lungs seen in tuberous sclerosis. Okay. In these patients, you can consider lung transplantation, all right? But I have seen it recur in the transplanted lung, all right? Because if you think about it, it's a smooth muscle cell abnormality. So even if you remove the lung, the abnormality is still being done. So that transplanted lung can, again, get the same findings. So this case, right, I actually read this out. I said, oh, I think there's maybe some infection here because I see it looks very hazy and reticular to me, okay? And they got a CT scan. And you can see there's just multiple cysts all throughout the lungs, all uniform, nothing bizarre about it, no thick walls. I called the pulmonologist. I said, oh, you know, does your patient, is someone with like tuberous sclerosis or anything like that? Because, you know, this looks like lymphangiomyomatosis. And that's what this was. You can actually, they can draw now this laboratory value of VEGF, VEGF, and if that's positive, you don't even need a biopsy, all right? So VEGF and innumerable lung cysts on CT scans is enough to make the diagnosis of lymphangiomyomatosis. Another case, okay, of lymphangiomyomatosis, and you'll have to believe me, like, you know, again, these cysts are not as uniform, but it's diffuse, and there was no thickening of the walls, all right? It doesn't look like Langerhans cell histiocytosis where it almost looks cavitary in some places. These are examples of tuberous sclerosis with the very nice fatty sort of lesions of the kidney. And then you can see that the lungs look identical to what we saw in lymphangiomyomatosis. These are the patients that we all learned about, had seizures, mental retardation, and also skin changes. Again, those of you who are into neurofibromatosis and neural imaging, you should know that there is, they do get lung manifestations. This is not a smoker, all right? This is someone who has neurofibromatosis. You can see it right here, all right? But you can see the patient also has cysts, all right? About 20% of patients with neurofibromatosis can have lung cysts. So you can be the fancy one when you're looking at their imaging and say, oh, look at the lung cysts, that's nice. You know, about 20% of them can get that. All right, and this is a case of neurofibromatosis with lung cysts. Almost there. LIP is another interstitial lung disease. This is very famously associated, all right, with Sjogren's syndrome. We learned before that UIP is famously associated with rheumatoid arthritis. We learned that we're going to learn that lymphocytic interstitial pneumonia is famously associated with Sjogren's syndrome. And what's great about the patients with LIP and Sjogren's syndrome, it's very easy. They just have cysts, nothing else. Just you could even count them, like 15 cysts, done. That's LIP if the patient has Sjogren's syndrome. The hard LIP, the difficult lymphocytic interstitial pneumonia, is in the patients who are immunocompromised, HIV, AIDS, or other sort of disease states. Because then, you know, come on, like, how am I supposed to come up with LIP in the setting of multifocal pneumonia and this one cyst here, all right? This was bronched, this came back LIP. Don't think that I said LIP when I read that, okay? But I just wanted to show you examples. This here, all right, there definitely are some cysts here. There is also some emphysema. This was an AIDS patient who smoked, all right? Don't think that I called this LIP either, but I just want to be honest with you that these are the difficult ones, all right? It's very different when you have Sjogren's syndrome, all right? And you can see, okay, clear, normal lungs and some cysts, all right? And then if they give you the history of Sjogren's, lymphocytic interstitial pneumonia, there's almost no differential. Another case, all right? You don't have to get fancy. If they give you this, all right, and they're going to, you know, they'll tell you a lot of history, particularly if it's a pulmonologist interested in interstitial lung disease, it's LIP. Finishing up, tracheobronchial papillomatosis, we know, is from the sort of HPV virus through the birth canal being aspirated by the infant. All right, and unfortunately, these poor patients, we know that there are all these papillomas in their airways, and then once they shed it into the lungs, all right, they have tracheobronchial papillomatosis, all right, and there's a theoretical risk for neoplasm, right? Theoretical risk for squamous cell cancer. I've never seen a squamous cell cancer arise, but you can see what it can look like. It's quite scary. But you know, this patient was only 21 years old. They can't go in and keep resecting and resecting and resecting. They just have to watch. Last couple of slides, and I know that we haven't addressed lung cancer as much, and lung cancer is so ubiquitous in all our nations. All right, but I think for all of us, what we have to remember is a ground glass nodule that hangs around longer than 3 months. All right, and whether they smoke or not. All right. How are we going to handle that? And that's maybe going to depend on resources, on follow-up, on your medical records, and your ability to contact patients. All right? I can tell you that any ground glass nodule that we see on any CT scan, we get follow-up, whether it be even in a year, all right? I think all of us here, though, we all have our iPhones. I know, and that's my timer going, I know that my family members won't wait a year, all right? But maybe my father, who's 81, okay, I'll wait a year to get a ground glass nodule. So you may have to gestalt it. But the literature says any ground glass nodule that persists longer than 3 months is at risk to be adenocarcinoma. However, a part solid nodule with solid and ground glass components is the one that has the highest sort of propensity to be neoplasm. So if you do see that, a ground glass and a part solid nodule together, all right, yes, that one would be the one. Don't wait 6 months. Don't wait a year. That's the one that you might want to image in 3 months to make sure. Okay? Just so you know, this patient, you would think that this is what killed him. In over 8 years, all right, this just had lipidic spread. It made some ground glass babies, right, like this, all right? And in actuality, it's this ground glass nodule that actually killed the patient, all right? And it was 8 years later. Through lung screening, every year we watched, and that's what killed him. Lastly, just to show you some cysts associated with adenocarcinoma, all right, the cysts can come over time. So if you follow these patients, the cysts will come over time, all right, and that's just from the mucin obstructing the airways and causing an explosion like we talked about with the secondary pulmonary lobule, and you can see these little cysts forming associated with ground glass nodules, and these are all examples of minimally invasive adenocarcinoma or adenocarcinoma in situ. Okay? So in conclusion, cysts are complex. It is a very tough entity, but I hope that I've given you some background to sort of sort it out when they come across your screen. Thank you.